And we were describing sort of that second step of platelet aggregation, where we began to see these components from the blood starting to adhere to that initial sticky region where we had that collagen and that von Willebrand factor. Okay, so just to jump back here for just a quick second, we spoke about an initial tissue injury, and apart from vasospasm, which is really the vessel's inherent way of sort of combating blood loss, we also begin to see the exposed collagen fibers adhere von Willebrand factor, and that starts making the region sticky and starts with that platelet adhesion or platelet aggregation. Now, once platelets start to aggregate at the site, they will secrete a couple of factors or products that will further create more platelet aggregation. So ADP, or adenosine diphosphate, is the first one. Again, that's going to be secreted in a positive feedback way, in that not only will it make the region sticky, but it's going to further aggregate more platelets, which will further secrete more ADP, and so on and so on. We also secrete serotonin and epinephrine. Both are vasoconstrictors, again, in an effort to decrease blood loss. These factors will cause vasoconstriction to the vessel itself. And so these are some of the things that will help make the region sticky, but also vasoconstrict and prevent that blood loss. The final product here, and probably the most important, is thromboxane A2. Also secreted in a positive feedback way, in that it's going to be secreted from platelets, it's going to aggregate more platelets, platelets are going to secrete more thromboxane A2, that's going to aggregate more platelets, and so on in a positive feedback type of way. As far as preventing this platelet plug, so in normal, healthy endothelial cells, they secrete two things that help to prevent this aggregation of platelets and this platelet plug formation. So that's prostacyclin, also called PGI2 or prostaglandin inhibitor 2, excuse me. And that again is secreted by healthy endothelial cells, and it's what prevents clot in normal endothelial cells in normal vessels. We've also got nitric oxide, which does a similar thing, right? So both of these is what keeps our blood flowing smoothly and prevents these platelets from sticking to the site. It just prevents that region from becoming sticky. So here's an illustration of that. So we've got the vessel. So this is our vessel, right? This is our lumen. This is our wall of the vessel. We've got the endothelial layer, and then we've got the subendothelial or the connective tissue layer here. So when we have an injury to a vessel, to an endothelial cell specifically, it's going to expose the underlying subendothelium, that underlying connective tissue. That has collagen fibers. When those collagen fibers get exposed, they start attracting von Willebrand factor, which is circulating in our blood. And we'll talk about this going forward, but most of the things that are needed for blood clotting are just normally circulating in the blood, okay? They're just turned on and off appropriately when the relevant circumstance arises. So we expose this collagen, von Willebrand factor can now start attracting or adhering to that collagen. And that is what makes the region initially sticky. And so beyond that, we now begin to aggregate platelets themselves. So platelets start sticking to that von Willebrand factor, which has now clung to that collagen. And this is where we start getting that second part of the process, which is that platelet aggregation. And so as we mentioned earlier, platelets are going to start aggregating here. They're going to secrete three things. They're going to secrete ADP. They're also going to be secreting epinephrine and serotonin, which are vasoconstrictors. So they are going to act on this smooth muscle lining here and start making the lumen very small in an attempt to decrease blood loss. And then the third thing we'll secrete is thromboxane A2, which again is going to aggregate more platelets. More platelets are going to secrete more of these things. More of these things are going to aggregate more platelets, and that can go on in this positive feedback loop. Okay, now over here, we can see what happens in a normal, healthy vessel with normal, healthy endothelial cells. They are secreting these two factors, prostacyclin and nitric oxide, which are preventing platelet aggregation, okay? Let's talk about the third, more permanent, more meaningful part of blood clotting. This is where we form that blood clot or that fibrin clot. This happens via coagulation, really. So basically the blood is converted to this semi-solid kind of jelly type consistency, and that's what we call a clot or a thrombus, okay? And we can see what a clot looks like on the right here. It's kind of this mesh-like structure that really is just like this jelly-like substance if you look at it externally. I'm sure we've all seen that. You've all had a cut. You've all seen that kind of jelly-like consistency, that substance that initially starts healing that wound or that site of exposure. And so it really starts aggregating other factors on top of that initial platelet plug to form a more stable fibrin clot or fibrin mesh, if you will. This is going to be the dominant, the most important hemostatic defense mechanism. In other words, vasospasm and the platelet plug formation are more temporary mechanisms. They don't actually stop the bleeding in a meaningful way. They don't actually heal the vessel, but this permanent fibrin clot formation is what actually gets in there and seals that exposure and begins to heal that wound in a more long-term way, okay? All right, what we're going to speak about now are the factors that are involved in that permanent fibrin clot, that more long-term sustained clot that actually helps heal that wound. And so before I kind of get into these pathways here, what I want you to understand is that these factors, again, are always in the blood. They're just inactivated. And so we want to activate them using other factors. So that creates this cascade, right? This kind of domino effect where we activate one factor, it activates another factor, it activates another factor, and so on until we eventually get to this, which is the desired outcome here, this fibrin, which is a stabilized permanent meshwork that seals that injury. Okay. The other thing I want to point out that's really important to understanding this is that the inactive form of these factors is just a Roman numeral. So it can be X, which is factor 10. It can be 2, which is the Roman numerals 2 here. We have factor 8, many different factors, but the inactivated form is just the Roman numeral. The active form is the Roman numeral with a small a. Okay, so factor 10 inactivated, and then factor 10A is going to be the activated form of that clotting factor. Okay. Now here, I only want you to focus on the terminal aspect of both of these pathways. They're really extensive and they're really kind of complicated at the proximal end. And I don't want you to think about the sort of memorizing the steps upstream, but I do want you to understand what's happening upstream and then really focus on memorizing this very terminal part of this pathway, okay? So we'll go over the terminal part of the pathway and then I'll show you the pathway upstream, which is the intrinsic and the extrinsic pathway. So both the intrinsic and extrinsic pathways kind of culminate together in this distal portion, which leads up to the fibrin clot formation. We have the inactive form factor 10 being activated to factor 10A. That is going to trigger the activation of prothrombin or factor 2 to thrombin or factor 2A, and it's going to require the help of factor 5, calcium, and then protein factor 3 or PF3 here, okay? So these are going to be cofactors that help factor 10A then convert prothrombin to thrombin, okay? Thrombin is going to do 3 things, and these 3 things are very important, so I want you to pay attention here. Thrombin is going to have a positive feedback onto the upstream parts of the cycle, the upstream parts of this cascade. So it's going to further sequester more activation of more of our factors upstream. The second thing thrombin is going to do, right, in its activated form, is it's going to activate fibrinogen to the active form fibrin. Okay, now fibrinogen to fibrin is more of a loose meshwork, sort of a slightly more less stable, less structured form of that clot. So it's going to activate fibrinogen to fibrin, right? That's the second thing that thrombin does. The third thing that thrombin does is it activates factor 13 to factor 13A, okay? And then factor 13A is what will stabilize that loose meshwork of that initial fibrin to a more stable, permanent fibrin meshwork or fibrin clot, okay? So let's go over that one more time here again. So the parts of the pathway that I think are really important that you need to know are the culmination of the extrinsic and intrinsic pathways. That happens via the activation of factor 10 to factor 10A, then factor 10A with the help of factor 5, calcium, and protein factor 3 will further activate prothrombin or factor 2 to thrombin or factor 2A. And then thrombin has three important roles. One is a positive feedback mechanism or response onto the upstream factors in this pathway. So it's going to create more factors. It's also going to create this fibrin loose meshwork, right? The initial activation of fibrinogen to this loose meshwork of fibrin. And then it's going to secrete, activate factor 13 to factor 13A, and then factor 13A will stabilize that initial loose fibrin meshwork into a more stable fibrin meshwork, okay? So again, this slide is just for your, so you can understand what's happening upstream. So don't be bothered or caught up with the upstream aspects of this pathway. This whole pathway gets really complicated. Unless you go to med school or grad school, you won't need to memorize this. But essentially, we've got this huge clotting cascade that culminates into this very distal pathway that it's more meaningful for you to understand for the scope of this class. Okay, so we've got the extrinsic pathway, the intrinsic pathway, and then they both culminate here to that thrombin, and then thrombin having those three important roles in terms of creating that stable meshwork of fibrin. I will point out where factor 8 is, because we'll speak about factor 8 in terms of its clinical relevance. This is where we get hemophilia. When we have the loss or the inappropriate action of factor 8, this is where we get hemophilia or excess bleeding. It's a bleeding disease because of the inactivation of this factor 8. So I'll touch on that later on. And so just to understand where factor 8 comes into play, it's really the end of the intrinsic pathway. Okay. All right. So just to kind of talk about this final part of the pathway here again, this is where I really want you to put your focus, the activation of prothrombin to thrombin with the help of factor 5, calcium, and protein factor 3, and then factor 10A really doing that activation. And then the three important roles that thrombin plays, right? The positive feedback loop, the activation of 13 to 13A, and then the activation of a fibrinogen to fibrin. And then 13A having that more stabilizing effect on that initial loose meshwork, okay? All right, let's talk about this. So this is kind of a redundant slide. So we talked about this, right? The fact that these clotting factors, they're made by the liver. They're always in the blood, but in their inactive form. And then they're just activated in this domino effect way, or this cascade way. When one factor gets turned on, it turns on the subsequent factor, and so on and so on and so on, until we get that fibrin clot formation. Now, if we were to take our plasma and remove all of these various clotting factors, von Willebrand included, what we have left back is called serum. So serum is the watery, solute part of our blood that has no role to play in clot formation. Okay, I'll say that again. If we took our plasma, the fluid part of our blood, remember plasma is if we took all the cells out. If we took that component of blood and we further removed all the clotting factors, what's left back is called blood serum. Okay, and serum has no role to play in clot formation because there are no clotting factors. Other important substances that are required, we spoke about calcium or factor 4, as well as platelet factor 3 or PF3, which is again required in assisting factor 10A in converting prothrombin to thrombin. So that first part of that, that culmination of those two pathways there. Now let's talk about what can limit clot formation. So on this slide, you're going to put prevent, right? This is really different from dissolving clots. So we can prevent clot formation with anticoagulants. And anticoagulants are proteins that are in the plasma and usually secreted by healthy endothelial cells here again. And these are things that prevent this clotting from happening in healthy, normal endothelial cells. One is going to be tissue factor pathway inhibitor. Tissue factor pathway inhibitor, also called TFPI, okay? That is, excuse me, again, secreted by healthy endothelial cells, and it's going to inhibit specifically the extrinsic pathway, okay? So although you don't know or you're not focusing on the details of the extrinsic pathway, do know that TFPI will inhibit that extrinsic part of that cascade or that pathway, and so in doing so, it will help prevent clot formation. The other factor here is thrombomodulin. And thrombomodulin, although it's not written here, you can make a note of this in your notes, that it actually inhibits both intrinsic and extrinsic pathways, okay? So TFPI inhibits extrinsic pathway, thrombomodulin inhibits both the extrinsic and the intrinsic pathways. Again, secreted by healthy endothelial cells, but it specifically is going to bind to thrombin and create this complex that will further activate something called protein C. So it's going to bind to thrombin. Remember, thrombin is going to be a part of the distal part of our cascade. And when it binds to that thrombin, this activates protein C, and protein C is another anticoagulant. In other words, it's going to prevent clot formation. It's going to prevent that fibrin meshwork, which is the distal part of that, that cascade. Okay. Now, on this slide, we'll talk about dissolving that clot. So just now we spoke about preventing clots. On this slide, we're going to talk about reversing clot formation. And so we want to think about homeostasis as we think about this, right? The fact that clotting should be happening in this balanced, healthy, medium way. We don't want excess clot formation, and we don't want too little clot formation, right? That's going to cause bleeding disorders and excess bleeding. But we want our blood to be able to clot appropriately only when there's injury. So not inappropriately too much and not inappropriately too little. And so we can dissolve clots if they're being formed excessively as a way to bring balance to that clot formation. So we do so via plasminogen activators. And what plasminogen activators do is they pretty much activate plasmin. They convert plasminogen, and the suffix gen here tells us that this is inactivated, and it converts that to plasmin. And so plasmin can enzymatically break down that fibrin clot. Okay, it's going to be able to dissolve that fibrin clot via an enzymatic reaction. Okay, and so an example of a plasminogen activator is tissue plasminogen activator, sometimes called TPA. And so TPA can do that same thing. It's going to basically activate plasmin, and then plasmin in and of itself can break down that fibrin clot, okay? Now, a really interesting feedback here is that fibrin, remember fibrin is that stable clot that we form at the end of our clotting cascade. Fibrin can then secrete tissue plasminogen activator, and tissue plasminogen activator can then convert plasminogen into plasmin, and plasmin can break down fibrin, okay? So fibrin can create the substance that will then activate plasmin, which will break itself down. So this is going to be a negative feedback type of relationship here. And this again is to prevent excess blood clotting and to help clot formation happen in a stable, happy medium type of way instead of excess clotting, which can lead to, you know, occlusion of vessels and a lot of other complications. Okay. So let's speak about the role of some of our clotting factors, and these are also called coagulation factors as well, right? Same idea here. And so if we have the loss of certain factors, we can end up having certain clinical diseases, which may lead to excess bleeding disorders. So hemophilia is going to be one of the main bleeding disorders. And as we talked about earlier, hemophilia is a deficiency in factor VIII, okay? So really that intrinsic part of the pathway. This is a genetic disorder, so you're kind of born with this deficiency. And so if you lose your genes that code for the production of factor VIII, you have a really hard time with cuts or minor injuries can lead to bleeding. These patients are very cautious throughout their life, and they don't usually live very long. As small as a simple shove or push can cause internal bleeding, can cause rupture of vessels, right? They're very, very sensitive because of their inability to clot appropriately. Another clotting disorder is called von Willebrand's disease. And as its name indicates, this is reduced levels or again, disruption in the function of von Willebrand factor. And we know von Willebrand factor was a part of that initial platelet plug formation. So if there's not adequate von Willebrand factor circulating in the blood, then it's not going to start aggregating to that collagen and creating that platelet plug formation. And again, we're going to see bleeding, easy bruising, and that type of thing in these patients. And then the final one here is vitamin K deficiency. Now, vitamin K is needed by the liver to synthesize these clotting factors. So if you have low vitamin K levels, and vitamin K is one of those fat-soluble vitamins, and so it's going to be able to be stored in the fat tissue easily. So it's not usually one that we see a deficiency of, but it can be, a deficiency can be brought about if you're not having it enough in the diet, or if you're having just general general vitamin deficiencies, I mean. So if we have a deficiency in vitamin K, the liver cannot produce these clotting factors adequately. And again, we can see bleeding disorders coming up in these patients. Alrighty. The final clinical important part here is aspirin. So aspirin is an anticoagulant, and I think someone brought up this point last time we met, speaking about blood thinners. So aspirin can act as a blood thinner, but only in a low dose. This is where we get that baby aspirin from. So usually, if someone is post-surgery or post-op, we're going to give them this anticoagulant to prevent this excess clot formation. Surgery is one of those conditions that can cause excess clot formation. Any type of injury or disruption to vessels can create excess clot formation. And so giving these patients low dose or baby aspirin actually inhibits the formation of thromboxane A2 and helps to prevent that platelet aggregation, okay? In high doses, aspirin actually has the opposite effect, right? Really interestingly here. So high dose aspirin actually inhibits the formation of prostacyclin. And if you remember from previous, prostacyclin is one of those substances that is secreted by healthy endothelial cells that prevents that platelet aggregation. And so if we have high doses of aspirin inhibiting prostacyclin formation, that is actually going to create more coagulation, right? It's going to prevent that normal flow of blood and create platelet aggregation or disrupt